I welcome you all to the every 2 weekly presentations by registrars of family medicine, Young Family Physicians Forum. Today's presenter is Dr. P.W.N. Teklani, registrar in the second year, and today she is going to present about 3 shades of darkness. And here I would like to quote from Shakespeare: "All my fond love thus do I blow to heaven, it's gone, and arise black vengeance from the hollow hell." It's the not only black vengeance, there are more shades to the darkness. To speak more about that, I would like to invite Dr. Teklani to present. And also I would like to specially mention Madam Lalanta Senaratna, who is always giving us feedbacks and guiding us in doing these presentations. So without much ado, I would like to invite Dr. Teklani. Thank you.
Thank you so much, Prabhat. You made me easy. Thank you for the kind introduction. Good evening, everyone. Our dear Madam, Dr. Lalanta Senaratna, and all my colleagues. You are warmly welcome to my presentation tonight. And I hope this would be an interesting session, and hope I can keep you all awake until the last minute. Well, as Dr. Prabhat explained, I'm going to talk about dark aspects of person's life that could come in 3 different ways. So I'm going to tell you about 3 different stories. Let's move to the story number 1 regarding the 37-year-old housewife who was presented to the medical ward following a drug overdose. Second story about a 46-year-old lady who was seen at the accident service coming with a laceration on her head. The last story about a little boy who is only 8 years, brought by his mother to their known family physician. The main complaint was poor school performance. So let's see what has happened to these 3 people. Case scenario 1 regarding this 32-year-old came with a deliberate self-harm. If I briefly summarize, she's been married for 3 years, but no children. She has not identified with any comorbids, so not on any treatment at the moment. She was brought by her husband to the hospital and later revealed that she has consumed overdose of diazepam, intending to commit suicide. And the acute management has been done at the medical ward. I know this is straightforward. Can somebody come up with any differentials for her presentation? Hello?
Severe depression.
Patient with depression.
Yeah. Any other thing before I move to the next slide?
Whether this is an act of impulsion.
Yeah, that's great. Yes, impulsive act of behavior. Yes, I agree. Shall I move to the next slide? So when I talk about the case scenario 2 regarding that lady who presented with a laceration on her head, if I summarize her story, she's been married for 22 years and having 2 sons, aged 21 years and 13 years. And we found out this laceration is after beaten by her husband. And at the same time, noted she's having some odd behavior, mainly talkativeness, over-talkativeness, and she was restless and bit aggressive. And this laceration was sutured and acute management was done. What could be the underlying reason for her presentation? Anyone?
Acute psychotic episode.
So why she was beaten by the husband?
Alcohol abuse.
Yeah, good. Any other thing? I know it's not easy to arrive at a diagnosis with this short history. Okay, let's move to the other story, the last one, about this boy. And to this family physician, they are known family. So this boy was born by normal vaginal delivery, not recognized or detected any antenatal or birth complications, developmental milestones were all age appropriated, not identified any significant disease in the present or past. But recently, the teacher has raised its complaint that his behavior was a bit hyperactive, that he was disturbing the teacher as well as his classmates during the past 6 or 7 months, and that lead to poor school performance. An initial assessment with history and examination found out there were no underlying medical cause. So what do you think?
ADHD?
Okay, but he was well until the past 7 months. ADHD would be appear, now he's 8 years, I agree. Maybe not detected.
Some traumatic event, possibly some domestic violence at home.
Yeah, could be.
About her mother's, has she give birth to another child?
No, this is the only child. Okay. Without taking much. Sorry?
Depression also can present like this sometimes.
Depression of the child or the mother?
Depression of the child even.
Child, yeah. Yeah, that's really, I agree with you. Okay. So after acute, identifying some differentials, what do you think the next step would have been? What could be the next step in management, next line in management? So all the acute management has been done except the third case, but rule out the medical causes. So as you said, what could be the next step?
Psychiatric referral.
Yeah. So,
Find the underlying cause for the impulsive activity of first one.
yeah. From the medical ward, what they have done was, after acute management, they have done a psychiatric referral. So as in this case, and this family physician, as he will know about this family, he also done a psychiatric referral. So they all were referred for a further psychiatric assessment. So regarding the case scenario 1, this is the basics. In every history, there should be these components. But when you take in a psychiatric history, we should pay attention or focus to some important elements in the history. So regarding this lady, there's nothing significant in her past medical history, surgical history. But past psychiatric history, there was one episode of mild to moderate depression, but no records were available at that time. That has happened 4 years ago, even before her marriage, after her father's death. And there were no previous history of deliberate self-harm. Only that depression episode was managed, but she has not followed up regularly or not on any treatment, currently not on any psychiatric treatment. And there were no family history of psychiatric illness within her family. But when you dig into the social history, there were lots of issues in her personal life. Her husband is working in a private company. So because we found there were lots of issues in her personal life, we took, anyway, we have to take a detailed history of personal history. So this is her personal history. She's educated up to A-levels. She has some behavioral things. She's very keen on tidiness, and she pays extra time, extra attention on cleaning, washing, mopping, and the family members took it as a positive thing. It's a blessing to have a daughter like this who is paying more attention to household things. But when we dig into the history, we found out she has so many negative ideas about her, especially inferiority about self-image, about her appearance, always thinking that she's not pretty, her husband is smarter than her, he could have married to somebody else, a pretty one, and so many negative ideas. And apart from that, she always has feeling worthless, loneliness, And there before the marriage, she had no love affairs, and this is also proposal marriage, and all the time she's getting these recurrent thoughts that her husband doesn't love or care about her as much as she does to him, and because of that she has developed lack of sexual desire. So in every psychiatric history, we have to take a collateral history. So what do you think the collateral history from the husband? This is what he revealed. There were multiple arguments between him and his wife. Wife is always suspicious about his infidelity. It has happened maybe 1.5 years or 2 years ago. Initially, the marriage was perfect one, but now currently there's restriction to his social life. Other than going to work and coming back home, he's actually not engaged in any social event because wife is always preventing him going to those things. And he's an occasional alcohol consumer, non-smoker, and he revealed that it is a very unhappy marriage. And so because he revealed such a story, we again went back to our main character in the story. She told this triggered by one event. Because she doesn't have any children, always they live with the mother-in-law, and there's also unmarried 40-year-old sister. This one is the only male son, he's the only son. So much attached to the mother and the sister. So she's not living in a good environment. And apart from that, she doesn't have any children. I think they are taking treatment. I'm not sure about that. She didn't reveal it. But mother-in-law is always accusing her. So when the things are like that, one day she caught her husband is watching a pornographic video. Then anyway, she's having these negative ideas that she's not pretty and she's not worthless, fear of that abandonment, that husband will go to somebody else, leaving her. This triggered and made her always after that checking his husband's behavior. She has questioned why because she didn't take it as a normal thing. She took it very seriously, that husband, because she's not pretty and husband is attracted to other ladies. He's watching of other sexual relationships. So she had this underlying belief that husband is having some relationship with somebody in his office. So anyway, she's getting these thoughts as an obsession. So this impulsive behavior, this deliberate self-harm, the previous night, she has, as usual, she has asked her husband not to attend to a party at the working place, but husband has gone. So she felt very sad, and this is, I'm not sure whether this is impulsive act or that she actually wanted to commit suicide. She has taken this diazepam, although she has over-the-counter Botican, consumed it with the thought of dying. You have any questions so far? You want to ask me something before?
Exactly. So what about her? Does she have any depressive features, insomnia?
Yeah, she has depressive symptoms. Yes,
Okay.
time to time she is getting. With the time, it's aggravating.
Okay.
But
Are there
mainly
any
she's getting-
suicidal notes?
No, nothing like that.
Then it's more in favor of impulsive life.
Yeah. But I'm not sure whether she wants to frighten the husband or not. But when we met her, she was really in a depressive symptoms.
Is this the first?
Yeah, this is the first time.
Any history of superficial relationships or other features of borderline personality disorder?
Yeah. I think when you go through this personal history, you can see she's having some features of borderline personalities, like negative ideas, previous relationship problems. No, I mean relationship problems, always suspecting thoughts. And can you just I wanted to highlight something else in her personal history, apart from some personality changes.
She was having this chronic emptiness, is it? And very
Actually,
suspicious.
sorry, I didn't get you, Karindra.
She was very suspicious.
Yeah, it happened after that triggering point. Before that, she didn't have any suspicious beliefs on her husband. She loves her a lot.
Who else in the family?
They live. They don't have children. They live with the husband's mother and unmarried sister. What do you think
Who is the
about
relative?
this
Yes.
extra attention on cleaning and everything?
It's for the
OCD?
personality
OCD?
disorder. Yes, again,
Yeah, either it could be a personality
tidiness
disorder.
also go with borderline personality disorder.
Yeah, it could be a borderline disorder, so it could be a OCD even. Okay, and this
Does
is
she
our
have any features of organic, like frontal lobe signs or symptoms?
what type of what kind of symptoms you mean? Hallucinations, like?
I know. I mean,
Yeah.
did you exclude all the organic things?
No such things have been done. You mean like CT brain or like that? Apart from the basic investigations, no.
So she's actually having an ancastic personality with
Yeah.
like borderline traits, right?
Yeah. Shall we move to the next scenario? This one, I won't go into the detailed past medical history because they are all normal. When we talk about this person's personal history, this lady, she's only studied up to grade 10. Husband is a salesman. And she has worked in a garment factory prior to marriage. And we reveal that she has been treated for some psychiatric illness, 2 or 3 episodes. But unfortunately, there were no reports with her, and it was totally defaulted follow-up and poor compliance. And there was a deliberate self-harm, 1 episode, and with similar psychiatric symptoms, there was a psychiatric illness in maternal side aunt. And the collateral history from husband revealed, it's tally with the his wife's story, previous 2 depression episodes according to him, with 1 deliberate self-harm. And this wife is always fighting with him, not trusting him and suspecting him, and those suspicions are always weird thoughts. He also cannot explain them. And he's an occasional alcoholic and a smoker. And because he cannot tolerate more, he started this domestic violence. That is their story. So when we examine the lady, these are the important examination findings we detected. She was well dressed with a good self-care and with a happy mood. Even though there's a laceration on the forehead and beaten by her husband, she was actually in elated mood, and her rate and flow and the pressure of speech all increased. And she was telling some delusional thoughts about infidelity of husband, and also having persecutory ideas and thinks that she has special powers because she has these beliefs that her husband is having some affairs there, even from the last verse when she was a princess, like that, some very odd talking. And she wants to harm husband and the other people, other woman who is having relationship with the husband, and she thinks she has special powers for this. And I think you can see it. They started managing it as a manic episodes. So what do you think has happened to this lady?
That is, during manic episode, patient has become aggressive, and that in that case, the anger control is poor, and that can cause
Husband battery.
husband battery. Yes.
Yeah, husband cannot tolerate. That's what
Tolerate.
husband told. Yes,
Yeah,
but
yeah.
the patient is actually in a manic episode. She's telling, about because sometimes she's happy about this. She's telling she was a princess and husband was the king, so he has so many queens. So it's not a problem for her. But when the manic episode increases, she gets this aggressive behavior, and she's also talking and about these relationships with the neighbors. Husband is very unhappy about that. And shall we move to the third one about this 8-year-old boy?
Yes.
Yeah. Actually, as you, some of you gave me the answers, actually this child is emotionally abusing in his own house due to so many family disputes between the parents. Father is an alcoholic. There are no financial issues. This one is working in a very good private firm with a good income, but he's addicted to alcohol. And he's always suspecting the mother. Even he's asking this 8-year-old boy to monitor the mom because she's a housewife, monitor the mom and report everything what happened from the morning to evening. And this lady is the one who's taking this boy to school and only doing those duties. But this father is asking this boy to report everything. So if she dressed with a nice dress, and he's getting suspicious. Now she's going out to meet somebody else. She always call her during the office time, and whenever it is engaged or call waiting appears, now he's thinking wife is talking to somebody else. Even she's late to open the door when he comes back home from office. Even she was late to open the door even for minutes. He's thinking that somebody's inside the house, and he took time for him to run away like that. So mother told she's having a very miserable life, and that was a totally unhappy marriage. Because of these things, the poor child, he cannot tolerate anymore, and he's taking revenge at the school in a different environment. He's fighting with his classmates, disturbing the teacher, not paying attention anymore. So when after a few days we talked to the husband, I'm not sure whether this is alcohol addict per se, or he's having these persistent delusions about his wife's infidelity. Do you have any questions before I move into next slides?
Husband might have morbid jealousy with the alcohol and...
Yeah. This is Dr. Finas.
Yes, yes.
Okay. Yeah. Any other thing? Shall we move?
Yes.
So basically, if I summarize, 3 different stories happen at 3 different places, but there's one underlying cause because they have come to one place to solve their problem. So what could be? Before I talk about my main topic, as Finas came out with it, what is jealousy? Is it a disease? If there is no, in the audience, if there's nobody who hasn't come with a jealousy idea, could you please press that icon, raise hand?
I think it's a natural thing, but as we are developed organisms, I think we can manage it, but whenever we couldn't manage, it comes out as
differently. Yeah.
Yes.
Okay, so this is simple jealousy. It's very simple in simple terms. It's a unhappiness, feeling unhappy, either become unhappy or become angry because you don't have, you can get something or someone that you like a lot. Like in this picture, can you see? The two people, closer to they cannot be happy with this victory. So it's basically feeling or showing resentment towards a person, a third person who thinks they take him as a enemy, and showing their unhappiness and anger. So as Dr. Faina said, this is a very normal thing, very common thing, but it's a complex thing. It can, in different people, it can come out in different ways. It could be pain, it could be grief, it could be hurt. It could be anger, hate, and fear of abandonment, feeling insecure, and it's a humiliated thing. And also it can come as mistrust and suspicion. So I think Dr. Prabhat just gave a hint to this. Have you heard of Othello syndrome? I'm sure you all must have. So this is regarding the Shakespeare's very famous drama, Othello, where the husband got suspicious beliefs about the faithful wife, but he eventually killed her and following that committed suicide. But you have heard in medical terms lots of syndromes. If you take it Down syndrome, there's one pathology, underlying chromosomal abnormality, trisomy 21. So earlier it told this Othello syndrome is one unitary syndrome, but now they have identified it is not so, because number of psychopathologies could be appear within separate psychiatric diagnoses. That's what we should identify and recognize initially. So I would like to talk, any definitive definition about morbid jealousy, anyone? Because I didn't include it. Anyone?
Right, Teklani, can I take time to talk?
Yes, madam.
This is now, all for all listeners. Now, Teklani nicely highlighted 3 scenarios. Why she, of course, she nicely presented all these things to describe the causes or possibilities for the morbid jealousy. It's just a word. There are different sort of aspects of morbid jealousy. There are different kinds of morbid jealousy. So different causes for morbid jealousy. To describe or make you understand clearly, that is the main reason of giving those 3 nice case scenarios to you all. So keep those things in your mind and focus her next part of discussion. Then you will understand why she presented those case scenarios. Okay, Teklani, go ahead.
Thank you so much, madam. So, morbid jealousy. It's actually range of very irrational thoughts and emotions which is associated with totally unacceptable behavior. It could be started with simply stalking behavior, like checking phone calls, messages, and stalking on Facebook and checking on the partner. And later on, eventually, it could lead to restriction of partner's life. As Madam highlighted in my 3 case scenarios, you may have noticed it when you think about retrospectively. And it could be ended up in physical violence, it could be domestic violence, it could be homicide. So killing the partner is the unfortunate last event if you don't manage and recognize it at the correct time. So basically, unlike normal jealousy, in morbid jealousy, it is mainly preoccupied with always partner's sexual unfaithfulness. So sexual unfaithfulness means having other relationships. It could be emotional or sexual, because in females it has recognized, even though they don't have, their husband is not engaged with any sexual activities, they're thinking, not thinking about any sexual relationship, but although if she believes that her husband is in love with another woman, that is also very, that can trigger to this morbid jealousy. But in the other side, the husband, male partners, it is more towards sexual relationships. They are very arrogant and about the sexual relationships. They don't care if it is love, but the most important thing is sexual relationships. So it's basically, this person is preoccupied with sexual unfaithfulness, but most of the time it's based on unacceptable evidence. Earlier, it has thought morbid jealousy can appear always with unacceptable evidence. But you have to remember, it can happen even when the partner is truly unfaithful. But the important thing is the way this person reacts is totally different to a normal people. For an example, if your wife or husband caught some extramarital affair with somebody else, what would be the normal person, how they react? Either they will fight, either they will question, they put on the anger, and but for the sake of the family or children, or either they move forward or live with the same person after forgiving, or they separate or divorce. That's the thing. And time to time, if they're living together, time to time, whenever they remember, they will just ask and fight or argue. That's it. That's a normal scenario. But these people, they behave, that's why I told, unacceptable and extreme behavior with irrational thoughts. You have to actually remember those things. And some studies says, but there are no evidence, in only one literature I found this, it could be a sign of extreme love and caring towards the partner, but it is also unacceptable. I mean, these persons can get morbid jealousy symptoms, but their underlying thing is they have extreme love and caring towards the partner. I hope you understand. I'll move to the next one. So healthy people, they can jealous. Even they can get jealous about the unfaithfulness or infidelity about the partner only at the presence of firm evidence, and they are very temporary. And it is toward a single enemy, single persons. Whenever they get the correct information or proofs, they modify their beliefs and reactions and they move forward. But these morbid jealousy people, however, we provide the evidence that the innocence, however, we try to convince them the innocence of their partner, they won't believe it. They just accuse the partner's infidelity, and not only single person. Within a period of time, they can accuse the partner with many other opposite sex people. And you have to remember there are 3 characteristics of morbid jealousy. There is either existence of a real enemy, real third person, or it could be a totally imaginary person. And because of this person, she or he is getting a threat that he or she will going to lose the loved one because of this third person. Then you get a reaction to eliminate the threat. So this basically the jealous happens in the context of a third person, and it could be that is what happens according to these 3 characteristics. And as I highlighted in the 3 case scenarios, it could be precipitated at any moment, but by any actual event or an imaginary event. And it can be associated with alcohol use and sexual dysfunction. But you have to remember in mind, because of lack of sexual dysfunction, they won't result in morbid jealousy, but it is the other way around. Because of morbid jealousy, they think the partner is having some other sexual relationships. He or she gets the inferiority that now I cannot do, I'm not good in sexual activities, then eventually get this sexual dysfunction. And the main thing is they persistently question their partner's whereabouts. Like I told, phone calls, text messages, emails, follow them, and even threats and repeated questions to grab the evidence that he or she is not having something. But this is keep on going. And this is distress to the partner as well as for him or herself. So most of the time accusations, as I said, based on the sexual relationships, it could be multiple partners, even the family members, own sister, close friends. They are suspecting close friends, their own sister or brothers, like that, family members. And there's physical violence. And it causes a misery in marital relationship because of these frequent accusations, arguments, physical violence, because severe restrictions of the partner's life. And the unfortunate thing is this could have a very negative impact on their children. But the unfortunate thing is most of the time that partner, the victim, is not, he or she doesn't understand this is a part of some psychiatric illness. They think this is extreme, just a behavioral thing. They just tolerate and move on. Why do you think I'm going to, I took this topic to talk today? Why it is important to us as family physicians? Any idea?
As it's usually hidden.
Yes, very good. Hidden.
And
It's
usually it is
prevalent.
missed.
Sorry, I didn't hear.
Usually it is missed.
Yes, it is missed and hidden. And
Not
why it is
prevalent.
important to family physicians?
Not uncommon.
Yeah, not uncommon, but not so common also.
It takes time to diagnose these things, and usually with the limited time available, all the
Yeah, yes,
things
limited time. Yeah, if that medical people or the family physician treat just the symptoms, we could have missed it, right? So they say it is encountered in primary care and psychiatry, especially in forensic psychiatry. And irrespective of whatever the field, all the clinicians should be familiar with its recognition and especially even the basic management. If you don't know any of the management, if you have the idea, if you don't know anything, just to refer them to psychiatric people would be enough. Because as Dr. Asian highlighted, this could become not only with psychiatric disorders like schizophrenia, affective disorders, depression, many other organic disorders like cerebral infarcts, head injury, road traffic, and also dementia, meningiomas like rare cases, also Parkinson's. So, and there's a threat to the other party. It could be husband or wife or the children, or it could be the third person. They could kill the third person with this jealousy. So it's very important then and there to identify and refer if you don't know the management. So when you talk about the epidemiology, the prevalence of morbid jealousy is unavailable because they have not done studies. Because though it's not an uncommon clinical problem, they have not done. So I couldn't find any data. You know, this thing is very difficult to treat. As you said, we could miss the cases hidden and they have not referred to psychiatry throughout lifetime. We may not detect it as a morbid jealousy. In the studies, some studies, they have found out it is more common in male patients. And 80% of them are still married and living together. There are no studies, this could be studies, there's no studies showing there's any association with ethnicity. But unlike in Asian countries, we have so many cultural things because we normally get married to end the life with the same person. But in some European countries, most of the time, it's not the same thing. They just marry or they have been living together, they separate with the same person and they start another affair. So it is little bit low in those countries where they don't have a true value to their relationships. And they have strongly identified there is association with alcohol dependence and other substance abuses. In Sri Lanka also, they have done studies. One study I highlighted, they have done this study in the involved patients. That means patients already diagnosed with psychiatric diseases like schizophrenia, BP, bipolar affective depressions, and they have detected they have a high prevalence. So they assumed if this is common with psychiatric people, there could be high prevalence in the community in our country. But unfortunately, there are very few studies done. So they have suggested in the conclusion, so need further studies to evaluate this problem. So regarding the psychopathology, mainly you have to remember either this jealousy, before the jealousy, this underlying mental disorder can appear before or with the jealousy can appear when it is having an underlying psychiatric disease. But you have to remember, as I highlighted in the fourth one, the jealousy can happen without any basis of psychiatric disease at all. I will talk about it later. So this is the spectrum of psychopathogenesis of morbid jealousy. This is important when managing a patient. So in one end, we call it delusional jealousy with lots of delusional ideas, like in the second one with the BP80, bipolar affective disorder, and the other spectrum is non-delusional jealousy with lots of obsessions with the lady who is having OCD symptoms and personality disorders. That is not non-delusional or obsessional jealousy. In between that, there's a so-called thing as overvalued ideas. Do you have any idea of that, these things? Shall I move to the other slide?
Yes,
Okay. So this is regarding the delusional jealousy. You know, delusions are false beliefs. Without any proof or reasonable evidence, the person gets these beliefs about the unfaithfulness of the partner. So, you know, the worst thing is, these are the worst things I highlighted. She or he may think that suspicious beliefs he or she is being poisoned or the given substance to decrease the sexual potency. And the partner may, because of he or she is having extramarital affairs, has contracted some STD and fear of having to him also, and having sexual intercourse while the subject sleeps. Those are very high delusional jealousy thoughts. And delusions of infidelity, always there's some underlying psychiatric disease, mainly schizophrenia, affective disorders, depression, and organic brain disorders. If it is basically a delusional jealousy. If it is an organic brain disorders, the underlying is psychopathogenesis is a delusional type. And if the patient is presented with delusional ideas, you always have to think about any cerebral insult as an infarction or injury. So what is this overvalued ideas? Anyone knows? It's in between delusion and obsessions. Anyone?
It is justified to a certain extent, but the idea takes over their life and interferes with their everyday functions.
Yeah, we'll see. So these are not delusions. They are acceptable and comprehensible ideas, but they act beyond the bounds of reasons and try to investigate about partners' fidelity. For an example, I will tell you. Sorry. For an example, I'm just giving an example on one example. You imagine the wife is suspecting the husband, and she's checking. Nowadays we are using WhatsApp now. So WhatsApp messages, she sees husband is online at the middle of night, and so-called third person is also online. Maybe they are not chatting with each other, but there are some acceptable things, and she's believing that they are having some chatting. They are having some relationship like that. So there are acceptable things, not a truth, but we cannot prove. It's a very different thing. You cannot prove even, and but she thinks we cannot prove that the husband or wife is wrong, but she's getting these ideas. Can you understand what I'm going to tell? Because overvalued ideas are more common with people with borderline personality disorders. So imagine the husband is calling the wife and line is engaging. Actually, she is talking to somebody, but that is not, could be some mother or some, not a unfaithfulness business. Can you get what I'm going to talk? I'm talking.
Yes.
Yeah, that is an overvalued idea, not a false belief. But when you keep on thinking, they are building their imaginary world and thinking their partner is unfaithful. So this is the borderline personality. Like in the first case, you highlighted it correctly. These I pointed out some of the important things. They are emotionally very unstable, always very anxious that they will at any point of their relationship, they could be rejected and being abandoned. That's their ultimate fear. And very unstable in interpersonal relationships, unstable self-image, negative self-model, I'm not pretty like things, feeling unworthless, and they can have impulsive behaviors like deliberate self-harm. Also, at the same time, they can get these recurrent ideas of unfaithfulness about their partner. So the other end, obsessional jealousy, as in the first one. So she's a person anyway with the OCD since the adolescent. Although family members take it as a positive thing, she has things. So likewise, it is triggered with the thing that she caught the husband is watching a pornography video. Then she's getting these obsessional thoughts of jealousy. There's recurring unpleasant, undesired, irrational thoughts. So it's a same way. So compulsive, when she gets a obsessive ideas, there's a compulsive, there's a action. So what is the action is excessive checking and reassurance checking. And he tries to restrict the freedom of the partner and always asking questions whether you love me, do you love me? She wants to declare their love. Or otherwise they are repeatedly telling, I love you like this. I care about you. Do you too? That is their main worry. Always they are getting recurrent thoughts. They cannot control it, like in any other OCD symptoms. So triggering factors of obsessional disorder, I don't want to repeatedly telling it. You can go through it like this. So normal versus obsessional jealousies. Normal people in obsessional jealousy, they are taking more time to think about these jealousy things and jealousy thoughts. It becomes eventually more distress to the person itself and make a very greater functional impairment. They don't have time to pay attention to household things, working environment. They are miss many things. Their mind is always thinking about these jealousy thoughts. So then later on, it affects the negative impact on the partner and the other family members. So what are the risks associated with morbid jealousy? They can get their confirmatory behavior, means their behavior pattern totally change. It can harm to themselves and risk to others, children, and they can develop other psychiatric disease because of this, like anxiety, depression, and substance misuse. So management of morbid jealousy, before managing, we have to, this requires a wide-ranging approach. We have to take a thorough psychiatric history. And you should remember, we should interview both partners, either it is separately or together, and mental state examination is very important. And with the history and examination, you should distinguish between whether this is a delusional pathology, obsessional, or just an overvalued idea, because treatment is totally different in these three broad categories. And we may need more than one interview to be conducted, and it's like sessions wise. So I highlighted this in my case scenarios. Personal history is important. Present and past psychiatric history, family history, any substance abuse, any history of domestic sexual violence and child abuse. So you have to take a thorough mental examination. I told it, I just put this slide. So principles of management, this is the important things. It depends on the three categories. If there is an underlying mental disorder, you have to admit or refer to the psychiatric people, and you have to treat with antipsychotics, and you have to manage the risk. Mainly we use, if there's an underlying psychiatric diseases like bipolar affective, risperidone, and if it is OCD like symptoms, you have to use fluoxetine, SSRIs or SSRI mainly. This is the important thing. Especially this will help with the people who is having overvalued ideas and obsessional jealousy. So psychosocial options will be cognitive behavioral therapy, like in any other things. If they are having obsessional jealousy, it should be exposure and response prevention, and couple therapy, dynamic psychotherapy, advanced therapies. I have not seen these practicing in our clinics. And if there's any substance abuse, alcohol or any other, you have to treat them. And especially we have to take actions regarding child protection procedures. And if you think that these should be needed inward care, then and there you have to admit for further management. The last but unfortunate thing is, if you actually cannot manage, the geographical separation means living apart from each other is the best option they have highlighted. So this is cognitive behavioral therapy. So what is, I will tell you briefly. So obsession is, she's getting recurrent thoughts about, jealousy thoughts about husband's infidelity. So what we ask is, okay, if you see a photograph of husband is with his colleagues or in the Facebook or anything, just look at the photo and remember that event. So she or he may get that feelings of infidelity feelings, obsessional thought, jealousy thoughts. So that is the obsession. But what is a normal procedure? They just repeatedly asking questions. So that is the response prevention. We slowly train them to resist this urge to ask it from the spouse for reassurance slowly. We cannot cure it at one single night. It should be started as a graded exposure like in any other things. And the other thing is possible exposure exercises. You have to let your partner enjoy. Initially, it will be difficult. It's like phobia management. If you have a phobic symptoms to go in a lift or a market, we ask in a graded exposure, okay, you stay there for 1 or 2 minutes. If you get the phobic symptoms, you go home back. So likewise, first you have to let your partner enjoy a film, watching a film alone, a match or something, even a pornography video, I don't know. I mean, observe, he or she could let the partner is talking with opposite sex people. So likewise, just we are training their mind to prevent these responses. So couple therapy, it's a very interesting thing. So in the couple therapy, the first thing is, so it's include individual or joint sessions. So what we ask is, first we let them talk to each other, because these people, they have never bothered or asked why he or she is getting suspicious beliefs about them. They take it as a normal thing, or this is their they just go on living with the same person. So we have to make sure understand why what happened to them. So we have to let them detect from each other. So first, how was their relationship before this jealousy began? And the third thing is, we have to ask how these jealousy feelings entered the relationship. Why and what are the reasons? This I put only one triggering factor. Why is he busy and he's coming late, not paying attention, or any other triggering point? Actually, she or he found a message to somebody, some colleague, and we have to find the triggering point by themselves, not us talking to them, each other, and they are finding the actual cause. Then only we have to intervene. Then only we have to intervene. Then in one couple therapy model, if the wife is getting suspicious thoughts, we are asking her, okay, now think, you exchange the models. Think you are the husband and see how distressive it is when he's asking you repeated questions about your whereabouts and checking your phone and not letting you go out and enjoy with your friends. See how miserable your life would be. So actually, it will take a lot of time to do these things. And it eventually may help both partners, because not only one person suffering because of both parties suffer because of this. The person who is getting jealousy people, I think, more suffering than the other person, because she or he cannot no control at all. So the prognosis, it actually depends on the underlying phenomenology, psychopathogenesis, existence of comorbid mental disorders, and the response to therapy. If there's underlying psychotic disorders, it's similar to other psychiatric diseases. It says there's poor prognosis with those categories. And morbid jealousy, it can recur, and careful monitoring is needed. So that's why family physician is needed. It's a kind of shared care among a psychiatrist and family physicians. Time to time, continuous monitoring should be there, because this is only controllable. Because some, especially obsessional and overvalued ideas, mainly depends on the psychosocial therapies. not on drugs, but like that. So conclusion, that's the end of my session. So you have to remember the morbid jealousy is a psychiatric illness. It's causing enormous distress to both parties, and it can associate with serious violence, suicide, and you have to then and there identify it early and treat to prevent further complications. And you have to remember this sentence, given the potential of tragic consequences, you have to remember it is a symptom that should be treated vigorously and taken with seriously. That's the end of my presentation. I hope you all are not sleeping. Do you have any questions? Because I have some questions for you. Hello?
Declan, we are here.
Yes, Declan.
Any questions?
Yeah,
Otherwise,
Dr.
I'm going to ask you
I
questions.
have one question.
Hello.
Yeah, this is Sindopa.
Hello, Dr. Sindopa.
Yeah,
Yes.
first I must say this is a very interesting presentation, and I think you kept everybody awake and throughout.
I hope so. Thank you so much.
Yeah, and I just want to ask now when you talk about the morbid jealousy, you told about the delusional. I mean, so you categorized it as some delusional. You highlighted the delusional aspect, and again about the obsessional aspect. So when we think about the diagnosis,
yes,
if we consider about the DSM-5 criteria or anything, is it the same as the other delusional disorders and other patients who are having OCD? Is it the same as the
yeah,
same as
if
those
it is
things?
underlying psychiatric disease, it
Yeah.
is same. But because morbid jealousy has not categorized, I
Yeah,
couldn't
that
find.
yeah, that's why I was also looking, and
You
there
are
was
correct.
no criteria.
No correct. But if there is such an underlying psychiatric disease, management and everything, criteria and all are same, Dr. Sindupa.
Okay, thank you.
Okay, thank you. Anyone else? Otherwise, I am going to ask from the audience whether you have actually participated or not.
Iklani,
Yeah.
what do you mean by like
Jamila, Dr. Jamila?
Yeah, dynamic psychotherapy.
Actually, they are advanced modalities. I didn't actually. I'm sorry. I didn't read. I didn't dig into those things. They are not actually practicing. They are advanced. I think they are for specialist psychiatric people. When we can't practice. The only thing we as family physicians can try cognitive behavioral therapy and couple therapy. The advanced things.
Yeah.
I think I also need to read about those things.
Hello. No,
Yes,
you need to read about it. It's good that you can enjoy learning those things. It's something else. But to add to Sindhupa's thing, the question and the way she presented about the wave, her waves.
Yes,
now the obsession. There are three types: the obsessional part of the delusion and the overvalued ones, right?
Yes,
and the obsession, and once, of course, you mentioned, when you love your your spouse more, that is another aspect you highlight.
Yes, madam.
Yeah, so that is an obsession again.
Yes, madam.
It's an obsession.
Yes, madam.
It's an obsession. So that is, of course, it's not love, it's obsession.
Obsession.
We term as it's love, but it's not love, right? Love is very different, because that's the usually what we see. What I'm always saying, the tip of the iceberg is just that, but it's obsession. The same, with that obsession, you cannot resist it, and it comes as the way you present it correctly, it comes as morbid jealousy, right? The same way, the delusions, the way you told, there are several delusions about herself or whatever the things. So then again, it can come as, one day, morbids. because their own issues. It's not somebody else's problem. It is your problem. Comes as a disease which harming your own one. Is it?
Yes, madam.
So that's the thing. So there are three aspects actually. Now the first aspect is it could be underlying psychological or psychiatric illness, or could be some personal issue, right? Or maybe organic issue. So we have to treat that one the same way that you answer for the Sindhupa's issue. There's all the diagnostic criteria for those things are same. So we have to treat that part. And then because of that, the person will end up with this. Your today's topic, this jealousy, Morbid's jealousy. So we have to, because of the jealousy, you observe the other affected party is suffering, and with that you also suffer. Not
Yes,
you are
madam.
not, the person is suffering a lot. So you have to treat that part as a separate entity. And the third important thing is the person who is affected. You know, we usually, when I see 10 people with this particular illness, actually the ones who, the person who got affected only comes and tell you about all these things, right? You know,
Yes,
this,
madam.
not the person who has the problem, the person who affected with the spouse problem. So it's a, you know, like a little bit of a, I think it should be not just one person can handle, it should be a teamwork. I think, you know, we have a good sort of role, and because we are like dealing with the whole family, they have the trust. We can get down people, we can get down the members of the family, like all these things, as well as we can get down, or even we can get the support of the psychotherapist, and we can get down some sort of people, say psychiatrists, the consultants, we can get the support from them, as well as if it is an organic thing, maybe a neurologist, right? Or maybe somebody else, you know, like if it's needed. So this is, you have to understand, it's not this is morbid jealousy, this is the treatment. It's not like that. You have to have some sort of a 360-degree evaluation and understanding the full context of the whole issue, and who are the what sort of the weight of the problem as the gravity of the issue. And the management plan is based on all these things. Like I'm telling you, it's a good one for a long case actually, because
Thank you
it's
so
sort of
much,
a,
madam.
yeah, it's a good, you know, the way
I
that's
was so scared that you would reject the topic, madam. To be frank, I initially thought you would reject the topic.
No, because I went through and I did some sort of like things to include.
Yeah.
Then only,
Exactly.
otherwise, you know, like by looking at the 3 stories at the beginning, it's like maybe, you know, it could be, or most of the people, they give the, you know, the diagnosis of depression or OCD, something like that, isn't it? So then,
Yes,
you
madam.
know, another thing, what we can understand, if a patient comes with depression, a patient comes with some OCD or something, the day I told you, not treating depression, not treating OCD is, you know, it's not the enough, means it's not the expectation. So we have to find out why the person got depression, why the underlying things. There's a huge story. That is the duty. So then with that only, all these things will come up. So I think that is our duty, not like the terminal end, what the psychiatrists do for the specifically to that story. We have a huge, huge role in that. So I think I highlighted that, and we had to understand our scope and what is our duty. It's good that it is for your interest to go to that and like understand everything, the bits and pieces, everything, but you have to understand your main role. So it's a very good thing, because most of the people, they ignore, and I know the suffering of this affected party. Because I know some people, though they are very innocent, they don't have any issue with the earlier. With this thing, they must so much of like getting affected with this like not continuous like battering, hammering, everything. And ultimately they end up with suicidal thoughts and depression. Or sometimes once a very recent one I got is the person with panic attacks, because when he or when she hears the noise of the husband, maybe a car or the gate opens, she get tremors, get the panic attacks. You know, that's the story. So we have to understand the whole, the depth of the issue and the gravity of the problem. Okay, then I'm just telling you, just adding to like some salt to your soup.
Thank you very much, madam. I think it is the most important part in this whole presentations. You nicely briefed, and as the way you guided me, I think you summarized everything.
Okay, then you all like you can discuss. I'm just listening. I'm not well. I had a very severe gastritis. Anyway, I want to go to sleep, and you all can discuss your questions. Is it all right to leave?
Only sure, madam. Only I need to thank Dr. Lalan Senaratna because I sent her the presentations actually this Monday, but she went through and she advised me, she corrected me, and I think we are privileged to have such a consultant with such a supervisor with us. Thank you very much, madam.
Okay, it's my pleasure to keep you all happy and make you all happy and do the best to get through the exams. Okay, then I'll make a move, right? Okay.
I made some questions. You can go through it. If you listen to it properly, I'm sure you listen to me and you just go through this. I'm not taking your time. Answers are also there. I don't know how to make a Google sheet and prepare that thing. So I just put it. These are the references. There are so many references you can go and read if you are interested in this topic. And I just wanted to actually show this one. This could be she or he. If she really has eyes on you, don't worry about who has eyes on her. So if you remember this, you can actually overcome this morbid jealousy. Thank you so much for actually participating, and that helped me a lot to move on. Thank you so much.